Tandem occlusions. Tandem occlusions is defined by acute ischemic stroke, with concomitant occlusive disease of the extracranial artery and concerned about 10% in the world. Endovascular treatment has shown its efficacy by large vessel occlusion, but there is no consensus on endovascular management of the extracranial carotid artery in tandem occlusion. Only few of them were included in previous randomized trials who evaluated mechanical thrombectomy and were often listed in non-inclusion criteria. Materials, we saw this slide, 99%, 18% tandem occlusions. Case 1, 58 years old male with left hemiparesis and left neglect syndrome, 20 points NICS. We can see the total occlusion of internal carotid artery, break through the occlusion after dilation, and we can see the thrombosis of middle cerebral artery after thrombectomy. Side view, but we had reocclusion of carotid artery, so we implanted stent. Final result, side view. Case 2, 35 years old male with quadriparesis and variable consciousness. NICS score 23 points. We can see dissection of right vertebral artery with distal embolization, distal access through dissection, thrombosis of right P1, thrombectomy. Patient was discharged at 6th day without any neurological deficiency. Endovascular therapy is the only way to treat tandem occlusions. It's effective and safe method. Results are depends on timing. And thank you for your attention. Some autumn flowers.
Perfect. Thank you. Yeah, tandem occlusions always a tricky topic because if you have to place a stent, often the patients are not on any blood thinners, on any antiplatelet therapy. So always the question, does one immediately place a stent, balloon angioplasty as well? Can you tell me about what is your antiplatelet regime and also your blood pressure management after the procedure?
We start with double antiplatelet therapy for 1 month, and now on monotherapy we continue. And the second question,
the blood pressure management.
The blood pressure management. Our experience shows that after the procedure, after recanalization, the blood pressure often normalize. But I'm cardiologist, and I don't have any problems with managing blood pressure. So this is not a problem for our team.
So what we usually do is after opening of the vessel, in order to prevent reperfusion injury as well, reperfusion bleed, we sometimes then lower the blood pressure in addition. Because of the vasovagal reactions, sometimes you already are lower, but if not...
Yes, now I can understand what is the question. we avoid dropping down the blood pressure. Even we don't use anesthesia for that reason.
Yes.
We treat patients with only local anesthesia.
We have a very similar management where at the beginning, when the vessel is occluded, we also leave the blood pressure high. We sometimes push the blood pressure even higher. If the blood pressure, sort of say 160, I would not lower a blood pressure if it's not above 220. And then the moment the vessel is open, we will lower the blood pressure, sometimes quite aggressively, to avoid the reperfusion hemorrhage.
No, we saw several cases of bradycardia in such cases, but dropping down the blood pressure is not so often.
Klaus, how is it in
Yes,
your experience?
bradycardia is due to the stimulation of the carotid body normally. And we do the same. We keep the blood pressure high up in the range of 160 systolic pressure or above before we open the artery to have more collateral blood flow to the tissue in danger. And afterwards, I go down to 100 to 120 systolic pressure because the patient is in the bed. He will not have a problem that the blood pressure is too low. And we have that risk reduced that we get some hemorrhage, some brain hemorrhage later on. So that is the same, yes, more or less the same
And from
method.
the management, as you were saying, if we have to put a stent in the acute phase, we have IV aspirin available as antiplatelet, and it takes about 10 minutes to work if you give it IV. So usually we would try giving IV aspirin before the intervention, even if the patient has had thrombolysis. I suppose that's what you were mentioning before, yes. Very interesting, very important topic. The important thing is tandem occlusion is not seldom. It is quite often, it is a reality.
Yes, this is 1% of 5.
Yes, it's also a complication of carotid artery disease. So you have a tight stenosis, perhaps not detected. Then you get an occlusion, and some of the material ends embolized in the brain arteries.
Iris, could I ask you a question? It's more for you, because you mentioned already the IV aspirin.
Yes.
In several instances, off-label, we have used the aspirin intra-arterially with impressive results.
Yes.
And even since several weeks, we had a case of a colleague of ours having a stroke during the job on the workplace. So we did intra-arterially fibrinolysis and small doses of intra-arterial aspirin, and the result was impressive.
I would be cautious with using intra-arterial aspirin because you get the aspirin in a pulver form, you shake it, you try and dissolve it, but actually if you look at it, there are very small particles still there. And if you then look at the WI, there is a very big risk of these particles also causing blockage. The question is it sufficient to receive an antiplatelet function? That you can test, and with the IV, as we're managing to lower it, that is why I would be very cautious with using intra-arterial aspirin. I'm not saying it didn't work, but I would be cautious, and I would then go for other things. So rioproabcicimab.
Pre-treat.
So if the patient comes in, and I know already that it's a carotid occlusion, or the moment I see it, I will tell the team, please draw up 500 milligram IV aspirin, and we give the aspirin on the table so that after that the stent is already in. So if it's extracranial, I would not wait for antiplatelet therapy for the 10 minutes to have worked. For intracranial, I am more cautious because we know how quickly intracranial vessels can block. there I would check. Sometimes we would also use clopidogrel, which you then have to crush, difficult, put through the nasogastric tube. If you go via that approach, it takes about 3 hours for the platelet function to be down. So
Great.
we have stats opening the vessel, keeping it open before placing the intracranial stent for 3 hours before we then placed it.
Please tell us, in this context, there is a huge discussion about heparin. Heparin not at all. Heparin only in the saline into the saline to purge the devices, or heparin full doses for full heparinization. There are different opinions, different, let's say, proofs or no proofs. What is your protocol?
So you will find very strong opinions, but very little evidence there.
Exactly, yeah, this is the problem.
What I find in our cases is that it is sufficient to have heparin in the flushes. So we use 5,000 units of heparin in 1 liter bag. And if I do see clotting and clotting occurs, that is when we react, and that is where we give additional heparin to the patient. You can do it under ACT control, or otherwise you give 5,000 for average 5,000 looking at the weight. But otherwise, we hardly see clotting. So I think it is sufficient to just have it in the flushes, but be prepared and always diligent. One big help or tool is if each syringe, I do not dispose them where I cannot see what is there. I want to see if there's clot forming. So each syringe, after we aspirate it, is dispelled on a white gauze. And if there are any pieces in there, that is react heparin.
Interest. Yeah, great. Thank you.
Small comment?
Yes, please.
Yes, I agree very much with you, Professor Petrov, and also with Iris. Intravenous aspirin is great. We use it, unfortunately, in Bulgaria. It's not everywhere readily available.
Yes.
And that is why we're also in, not only in stroke, but also in other procedures, we have to use clopidogrel or Brilic with aspirin preoperatively, which makes it difficult sometimes. If we're in an emergency situation, we need to use IV antiplatelets. It's a problematic situation, but IV antiplatelets obviously save lives. So I think that it's the important thing is to have it readily. In Bulgaria, it's not available in our hospitals. So this is a problem for us, obviously, in many patients. That's why I think also the colleagues in most cases are using clopidogrel or aspirin, or if the patient is resistant, Brilic with aspirin through the nasogastric tube.
The problem with RioPro, abcicimab, GP2B3A inhibitors is that if you start giving it, so sometimes we think, oh, let's just give a little bit. Actually, that has a paradoxical effect doing that. So you have to give, if you decide to go that way, you'd have to go the whole dose. And obviously, in patients with an acute stroke, probably thrombolysis, you would want to avoid that. Yes.
Absolutely.
Good. Yes.
Okay. So,
Thank you.
Yes, I want only to thank you again for your presentations. Yes, very informative. And we go on in the